Hello and welcome. We are excited to offer you this training, Implementing the TIA PHN Model. TIA PHN stands for Trauma-Informed Approach in Public Health Nursing. This training is designed to provide specific information related to the implementation of this model within a field nursing or other nurse home visiting team. Much of the information included in this training is also available in the TIA PHN Guidebook. If you do not yet have a copy of your guidebook, please visit our webpage to request that a copy be sent to you. The objectives of this training are that participants will understand the history of the TIA PHN model and why it was developed, understand the different components of implementation of the TIA PHN model as part of your practice and within your organization, and identify resources available to help support implementation of this model. Next, I'll provide a little bit of background. This model was developed in order to meet the increasing needs of the Sonoma County field nursing clients and their families. After the 2017 Tubbs fire, in which over 5,000 homes were destroyed, we saw a great increase in acuity among our clients, including families experiencing domestic and intimate partner violence, substance use, mental health challenges, and housing insecurity. Many families referred to our program had trauma histories that were not being acknowledged or addressed in traditional field nursing or medical models used at the clinics. In order to help our families achieve their goals, the Sonoma County field nursing team developed this model, which provides a standardized trauma-informed approach while also embracing clinician discretion to meet the individual needs of clients. The TIA PHN model also acknowledges secondary trauma and that staff themselves may have their own trauma histories, and ensures that a trauma-informed approach is used within the TIA PHN team between team members. So why use the TIA PHN model? As we just reviewed, the model was designed to meet the needs of our most high-risk families. By addressing adverse childhood experiences, we hope to work with our clients to disrupt the cycle of trauma. This model acknowledges the need for a trauma-informed approach within the field nursing team members as well as with our clients. It incorporates ACEs screening and supportive education in a client-led approach with mutual goal setting. It relies on clinician discretion and individualization in how we implement the model to best meet needs of our clients. It also uses a multidisciplinary team, including public health nurses, community health workers, and social workers. And lastly, the model addresses the lack of an evidence base in traditional field nursing programs. We want to take a moment to recognize the work that home visiting public health nurses do every day that allows us to be in a unique position to provide client care using a trauma-informed approach. PHNs meet the client where they are and don't make assumptions. We trust our clients to know themselves, and our clients trust us and know that we will advocate for them and help support them. Recognizing trauma histories is one way that we can provide support. We have the privilege of meeting clients in their home and the luxury of being able to take time with our clients to listen and allow them to lead us in the education and support that they need. Now that you have a little background on the TIA PHN model, it is important to understand what the overall goals of this model are. We break our goals out into two categories: the goals for our clients and the procedural goals of the staff for the program. As we learned in the ACEs training video by Liz George, exposure to childhood trauma and toxic stress places an individual at higher risk for conditions such as substance misuse, mental health challenges, cardiac conditions, and cancers. For our clients, the general goals of the model are to acknowledge past trauma and help clients find ways to mitigate toxic stress, find resilience, and to optimize a client's healthiest state to address their higher than normal risk of toxic stress and future trauma. The procedural goals for staff using the TIA PHN model are to use a trauma-informed approach with every family, complete an ACEs conversation with every family, complete a depression screening for each enrolled primary caregiver, complete a developmental screening for each enrolled child, and to ensure consistent recording of our results. So now that we've reviewed the goals of the model, let's go over the specific components of the model. Hopefully you've had a chance to look through the TIA PHN guidebook prior to watching this training. If you don't have a copy, please visit our website to request one. The TIA PHN Guidebook provides detailed instructions on each of the model components listed here. So the components of the model include voluntary enrollment and participation, assessment of needs in the development of an individual service plan. This includes case identification through offering a depression screen to all primary caregivers and a developmental screen to all enrolled children, having an ACEs conversation, delivering the model curriculum, incorporating trauma-informed principles into practice, and lastly, evaluation for tracking and measuring our outcomes. So now we'll go through each of these components in a little more detail. So let's start with the enrollment process. Referrals who meet the following medical and social risk factors should be prioritized for enrollment in the TIA PHN program. Current homelessness or housing insecurity, past or current substance use, past or current intimate partner violence or domestic violence, past or current mental health concerns, and medical fragility, especially when a condition jeopardizes pregnancy or interferes with effective parenting. When screening referrals, we also want to consider the following circumstances that may affect a client's ability to reach their healthiest state: the lack of transportation, which may affect access to needed services, food insecurity, difficulty navigating healthcare systems, and community resources due to language barriers or recent immigration. All individuals referred to the program must be notified that their participation is completely voluntary and that they may discontinue services at any time. So next we'll look at the nursing assessment and the development of an individual service plan. A comprehensive medical and social assessment will be completed by the nurse at enrollment and every 6 months. The nurse should use a client-centered approach to develop a plan that addresses the needs identified in the assessment, as well as any barriers to services, with the goal of optimizing health and well-being. The individual service plan should be developed with the client's input. This plan will be reevaluated and updated with the client every 6 months and as needed. The medical assessment includes an assessment of any current and past medical history, linkage to and use of primary medical and dental care providers, assessment of any outstanding immunizations, and any barriers to medical services experienced by the client. The social assessment includes an assessment of housing status, family and support systems, access to and utilization of resources, past or current use of substances, past or current exposure to intimate partner or domestic violence, and any history of emotional and mental health concerns. As part of the nursing assessment, all primary caregivers should be offered a depression screening using a validated screening tool. In Sonoma County, we are using the Edinburgh for any clients who are pregnant or up to 12 months postpartum, and the personal health questionnaire, or the PHQ-9, for any clients who are not pregnant or postpartum. These screenings do not need to be done at a specific visit, but should be done prior to a client's exit from the program. When indicated and desired by the client, clients are linked to medical and social support services to address mental health needs. All staff using these tools should be trained on their use. 2 things we encourage TIA PHN teams to do is to ensure that the screening tools are made available on a client's preferred language and that we respect a client's decision to decline screening, regardless of symptoms. All parents enrolled in the TIA PHN program should be offered a developmental screening for their children using a validated screening tool such as the ASQ3 or the PEDS and PEDS-DM. And again, we encourage TIA PHN teams to offer these screenings in a client's preferred language. When indicated and with parental consent, children will be referred to early intervention services. So now we'll go into the next component of the model, the ACEs conversation. The nurse should have a client-led conversation that includes information about ACEs, including how they can affect brain development and health. Clients will be offered an ACEs questionnaire to complete with the opportunity to reflect on past experiences if desired. It is not necessary for a client to complete the questionnaire, but they should be offered one if they'd like one. So some things to remember when having an ACEs conversation. Ask permission. This has to be voluntary. Privacy is crucial. Allow clients to disclose as much or as little as they choose. The conversation is more important than the ACEs questionnaire. Provide positive ways to promote resilience, and thank the client for sharing with you. Throughout each visit, the nurse will encourage clients in self-reflection and discuss behavioral choices that maximize health and well-being while minimizing toxic stress. So you may be wondering, when is the best time to have an ACEs conversation with a client? In Sonoma County, we found that nurses had this conversation most frequently at the second visit. But you can see from this graph that there was quite a range, with one person having the conversation on their 20th visit. Oops. And when having an ACEs conversation with a client, we often use this handout from the Robert Wood Johnson Foundation. It provides a nice visual summary of the original ACEs study, showing prevalence of the different types of ACEs and the relationship between ACEs score and behavior and physical and mental health. So now let's talk about the TIA PHN curriculum. In order to help standardize our approach in providing education about ACEs, resiliency building factors, and using trauma-informed principles, we developed the TIA PHN curriculum. This curriculum includes trauma-informed education tailored to meet the individual needs of the client and ensures all clients are treated in a way that acknowledges past and present trauma and avoids re-traumatization. The TIA PHN curriculum can be divided into 3 categories. The first 2 are brain development and ACEs, and trauma-informed care during pregnancy and postpartum. And the third category, lowering toxic stress, includes information on the following 6 subcategories: nutrition, sleep, exercise, relationships, mental health, and mindfulness. When delivering the model curriculum, we rely on each nurse to trust his or her judgment in terms of the timing and the delivery of the information, to ensure that the education provided is done so in a way that will meet the needs of the client and that the client is engaged and interested in receiving the information. The model does not require that each client be provided with education on each of the curriculum topics. You may find that you are working with a client who is interested in learning more about nutrition and sleep, but not mindfulness, or that a client is not pregnant or postpartum while they are enrolled. In these instances, the mindfulness curriculum for the first example and the trauma-informed care during pregnancy and postpartum curriculum for the second example may never be addressed with the client, and that's okay. So does this mean that you have to follow a script when talking to clients? No. The curriculum was created to provide a standardized approach, but it is not a cookie-cutter, one-size-fits-all conversation that we have to have with each client. We know that the relationship you develop with your client is paramount, and we need you, as the clinician, to use your judgment to know when and how to provide situation-specific education and resources to clients using a trauma-informed approach. When you see the curriculum in the guidebook, you'll notice that we provide a prompt that can be used for each topic. This helps us get the conversation started, especially if a nurse is feeling a little apprehensive. The prompt can be used to guide these conversations with clients in a way that incorporates trauma-informed principles and ways to build resilience. So here's an example of the curriculum form in the guidebook. The forms you use within your program may look different. In Sonoma County, we've adapted this form into our electronic medical record, and we'll show you what we are used a little later on in this training in terms of tracking. The curriculum here in this example is specific to mental health within the framework of lowering toxic stress. Each curriculum topic includes information about the general concept, a clinician caution, which helps us avoid making common errors that can impact delivery and understanding of education and possibly even cause re-traumatization of the client. And then topics to be covered as part of the education and a list of relevant referrals. The Sonoma County Field Nursing team created this handout, which is available in both Spanish and English, which reviews the 6 resiliency factors that are part of the lowering toxic stress curriculum. So this handout can be edited to reflect your local resources and is a great tool to use in providing education with clients. In Sonoma County, we have this handout paired with the ACES handout from the Robert Wood Johnson Foundation that we reviewed earlier. We combine these two pages to make a double-sided handout for clients when discussing ACEs and what they are, and then on the back, ways to help reduce toxic stress at home. So we want to take another moment here just to recognize that many of our visits have been and they continue to be remote visits due to COVID. So much of what is special about being a home visitor is the ability to take time, meet face-to-face, develop rapport, and read body language and facial expressions. Obviously, these things are different when doing remote visits. Because of this, it may feel awkward or intimidating to have an ACEs conversation or talk about trauma, especially with new clients. On top of the difficulties in developing that rapport, there may be connection issues, dropped calls, or choppy video. These can all impact how successful a conversation about ACEs and trauma can feel. Maybe you've already been having ACEs conversations and talking about trauma with patients or clients for so long now that it feels natural. However, for those of us that might be new to having these sort of conversations by phone or video visit, we want to recognize that it can be challenging and uncomfortable. All right, so now that we've reviewed the enrollment, the development of an individual service plan, and the TIA PHN curriculum, let's review how we incorporate trauma-informed principles into practice. Hopefully by now you've already watched the training on taking a trauma-informed care approach, applications to home visiting teams by Julian Ballard. Public health nurses using the TIA PHN model will utilize the SAMHSA framework and adhere to the following principles in order to avoid re-traumatization of clients and staff. Safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. TIA PHN staff will commit to regular training on trauma-informed practices and will engage in reflective supervision with their supervisor. Organizations using the TIA PHN model should ensure that organizational messaging reflect the use of the trauma-informed approach in client documentation, internal and external communications, and brochures. And now we'll go through evaluation. For the TIA PHN model, the evaluation will include both a process evaluation and an outcome evaluation. Process evaluation refers to how the model is implemented by each field nursing team. For example, are all enrolled clients being offered education from the TIA PHN curriculum? Are they all being offered an ACEs conversation and questionnaire? Outcome evaluation, which refers to how many of our clients reach certain client-based outcomes. For example, was a client who was postpartum while she was enrolled in the program seen by her doctor for a postpartum visit? And was a client without a medical home linked to a medical home while he or she was enrolled? In the future, we hope to be able to measure more long-term effects of this model. Ideally, we'll be able to measure how TIA PHN clients have utilized the education provided through TIA PHN curriculum in their daily lives to reach their goals. We also hope to be able to evaluate the TIA PHN model's ability to impact or reduce exposure to adverse childhood experiences from one generation to another. All of the measures used to evaluate the TIA PHN model, the process measures, the outcome measures, and the demographic data are included in the TIA PHN Data Dictionary, which is included as an appendix in the TIA PHN Guidebook. So as I said previously, the process evaluation refers to how the model is being implemented by each county. This slide shows a picture of the form in our electronic medical record that allows us to document the process measures for each primary caregiver client at the time they exit the program. It's important that all staff on the TIA PHN team are consistent, objective, and complete in their documentation. So looking at this example, you can see how we would be able to record the number of times a client was delivered each component of the TIA PHN curriculum by completing those boxes on the right. We'd also be able to record if and when, or at what visit number, a client received the ACEs conversation and or was given the questionnaire. Another part of the process evaluation is fidelity. Fidelity refers to how well we, each TIA PHN team, are sticking to this model and providing our services in a similar way. In order for us to understand how effective the model is, we need to know that we are all following the model consistently and as outlined in the guidebook. The TIA PHN fidelity measures include client caseload. So the PHN will carry a caseload of 25 primary clients if they're working full-time. A ratio of supervising PHNs to PHNs of 1 to 6. A monthly encounter rate of 48 to 60 face-to-face encounters in a typical month, which translates to approximately 12 to 15 visits per week. A visit frequency of at least one client visit every 30 days. Weekly staff meetings, which allow for case conferencing and trauma-informed support of staff. Reflective supervision in one-on-one meetings to allow for individual reflective supervision, and a participant retention rate. As part of the outcome evaluation, the TIA PHN model uses HEDIS measures for many of the client-based short-term outcome measures. HEDIS stands for Health Effectiveness Data and Information Set. HEDIS measures are used by the National Committee for Quality Assurance and are collected by many healthcare providers and facilities, as well as Medi-Cal or Medicaid administrators, which makes them ideal for use as a comparison group. For TIA PHN, we will look at the following short-term outcome measures at the time a client exits the program. For adults, prenatal and postpartum care, Tdap during pregnancy, contraceptive use within 6 months postpartum, linkage to health insurance, linkage to medical and dental homes. And for children, we'll be looking at well-child checks, childhood immunizations, and breastfeeding. We will also look at screenings and referrals for depression for adult caregivers and developmental screenings for children. This is a picture of our electronic medical record tracking form used for our outcome measures. As you can see, there's a box where we can track whether or not each of these outcomes was met by an adult client, the first set of measures, or a child client in the second set of measures. So why do we need to evaluate ourselves? You never know how things are until you look. Unfortunately, funding for public health programs is spread thin due to many competing needs within our community. Those models that are evidence-based are more likely to be selected for funding due to their proven efficacy. And of course, a program cannot become evidence-based without conducting an evaluation of the program. And here's a little note about the importance of becoming evidence-based. It's important to understand the current status of field nursing programs with regards to being evidence-informed or evidence-based. Program evaluation is required to achieve a status of evidence-informed or evidence-based. However, evaluation of traditional field nursing has been challenging due to the high acuity and high risk levels of our client base. Currently, proven effectiveness is increasingly required to secure funding. Completing regular evaluations and using data-driven decision-making results in meeting the true needs of our community, because without an evaluation, we will never know whether or not our services are effective. All right, so lastly, we want to make sure you know what resources are available to you as you implement this model within your program. We have our TIA PHN website listed here, which can be used to request a copy of our TIA PHN guidebook, which is also a resource. And we have the PACES connection. PACES stands for Positive and Adverse Childhood Experiences. This group used to be known as ACES Connection. Their website is www.acesconnectioninfo.com, and they are great resources for ACE They are a great resource for ACEs-related education and research. Thank you for your time and for your attention. We would love to hear from you. Please send us any questions or comments by visiting the Contact Us section of our webpage.